Morning to you, ladies and gentlemen. Yang berhormat Dr. Lee Boon Chai, Yang berhormat Dr. Kelvin, yang berbahagia Datuk Amal Singh, yang berbahagia Prof. Habibah and Azrul, and all of you, ladies and gentlemen. I think I'm very encouraged to see so many young minds in the audience, and I'm sure you'll have difficult questions for us, and we expect difficult questions. Because as Dr. Amal Singh mentioned just now, you are the future. All right, I am the past. I'm not sure about the other two. But perhaps I can share with you something about what has happened to the healthcare scenario over the past couple of years. Now, before we do that, I want to just mention one thing. Health is a basic need of the people. We all know that. And the government is obligated to provide it. Now, that is a very important statement. Now, the WHO has expounded this statement in its constitution, and I quote, "The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic or social condition," unquote. So the right to health for all means that everyone should have access to the health services they need, when and where they need them, without suffering financial hardship, and no one should get sick and die just because they are poor or because they cannot access the health services that they need. So that is the motherhood statement for the whole healthcare sector. All right. Now, what about Malaysia? Malaysia is a high middle income country with 32 million people. We have an increasing elderly population. Right now, 6.2, going to be 7 in 2020. But you people comprises quite a bit as well. About 70% of the present 20 million fall between the 15 to 64-year age group. So you should be able to give us some ideas on how you would like to charge the direction of the future healthcare system. Now, you must be aware of the challenges that we have at the moment. The first challenge, I always mention this, is a highly subsidized government healthcare service. And because of that, we see huge crowds, we see disparities in quality of care, blah, blah, blah. You know the rest. The second thing is the changing pattern of diseases. We are seeing more NCDs, non-communicable diseases like diabetes, hypertension, hypercholesterolemia, cancer. But we are also seeing an emergence of communicable diseases like dengue, TB, and the rest. And of course, we have a huge aging population coming up that poses a challenge to all of us as well. And the third problem is the public-private dichotomy. We don't have an integrated healthcare system. But I understand from Dr. Amal Singh, healthcare financing and integration will be addressed at another forum. So I won't be at the liberty to mention any of these, which are things that are very close to my heart.
I think you can, not to worry.
Okay, fantastic. So with public-private dichotomy, there is bound to be inequitable distribution of resources. And there is increasing healthcare costs, which may render our present healthcare system non-sustainable. We've got increasing consumer demand, all of you, for quality services. You read a lot on the internet, you want better services, you want quality services. You will not, go around getting substandard healthcare. And we have to keep pace with advances in medical treatment and technology, and of course ensuring patient safety and ensuring there are no medical errors. So when we talk about policy, I was in Minister of Health before. What do we do? How do we formulate policy? Dr. Yang Berhormat Lee Boon Chai is here now. He's in the stewardship role. We look towards him and the Minister of Health to make sure they do things that could not be done when I was DG. Somebody was asking me, why didn't you do all this when you were the DG? So I told that somebody, I did. I presented the Prime Minister, I presented the Minister of Health. I did my battle. But as you know, in this country, you cannot get anything done without political will. So now we have a new government, we have a new set of dynamic ministers and deputy minister, so we look towards them to make sure that they make the changes, they do the healthcare reform that I couldn't do when I was DG because of the old previous government. I think there's a lot for me to say, but I think I will stop there. I will stop there so that you can ask me later any other questions you want to address. Thank you so much. Yeah? Okay, bye.
Thank you very much for keeping the time and for making that short and sweet. That's very good. Okay, we're going to move on to Dr. Lee Boon Chai, and all of you know him as our Deputy Health Minister, but some of you may not know he's a cardiologist and an adult physician, and I think he was reluctant to give up his practice because he knows he can't go back to it once he's been Health Minister for 5 years. But perhaps the 3 words to describe him best. He's my junior in MU, so kind of kaki, friend, huh? So 3 words to describe him: he's a very humble man, his integrity level is very high, and he's very interested with people on the ground. I mean, he's a down-to-earth guy, and we hope that's the kind of thing you're going to see from him. So could we invite him, please?
Thank you, Amar. That's what I used to call him since Students' Day. He was one of my mentors in my student activist career. And here I am, re-entering the arena. Tan Sri, Ismail, YB, Kelvin, and friends. I still remember this auditorium. Still the same. When I first came, I think one of the memorable lecture was when HIV infection was in the initial stage, and we have this Masale guy, no Masale around, come and talk about what an unexplained disease which was actually devastating effect on immunity, and at that time was talking about how the thing was transmitted. And nobody seems to know what was happening, and it was called AIDS at that time, and of course subsequently that was history. We knew it was HIV infection. I'd like to thank the organizer for organizing this event, for allowing me to come back to this auditorium again, and certainly it's very useful because I know that a lot of you are overseas, and take this opportunity to come back and have some view on what is happening in Malaysia. Of course, Tan Sri Ismail has given you a very holistic and very ideal view of what WHO has promised. I wouldn't repeat the statement, which I think I have difficulty in repeating the statement, but I'm just telling you what is facts. Okay, first of all, the ideal one, the preferred one would be something like universal healthcare, where everybody can enjoy affordable and quality healthcare. But we are also living in the situation where, as what Tan Sri has said, we have a dichotomy. This dichotomy came about because we respect choice. I always say that, if we can remove everything, treat everybody equal, treat everybody the same, and we give treatment for everybody the same way, whether you are A, B, or C, then the communist country would have provided the best model. But as a matter of fact, I think most of the communist country or the socialist model has failed. Has failed because I think they have failed to deal with human factor. Basically, I would like to say that humans are basically selfish in nature. So that's a fact. We like to be very holy and talk about self-sacrifice, but a lot of the time, even if you have say 99% of people who are selfless, contributed to good cause and so on, but you just need 1% who is selfish, and you will destroy the whole system, and the system doesn't work. So that's where we respect choice. When you respect choice, then there will always be dichotomy. In fact, when you respect choice, there will always be inequality in terms of standard of care. Because when you respect choice, it will mean that the one who can afford the one who can buy, ability to buy, will invariably get better healthcare. Let's face it, that's reality. So in the current system in Malaysia, even in all over the world, it's the same. When you respect choice, there will always be inequality. There will be people who say that, you know, it's good to have free healthcare for all. I think Dr. Amar would like to tell you that he will say that the free healthcare for all will be the ideal system. But I would like to rebut that free healthcare for all, in fact, is the most expensive healthcare. Free healthcare for all, if it works, the socialists or the communists would have done it. When you give free healthcare, it will mean that lots of people, the consumer, will be able to abuse the system, and there will not be optimization of the resources provided. So at the end of the day, I think I wouldn't say ideal model. I would say a good model will somehow where the consumer or the patient will take some responsibility of their own health. That's where they would provide some check and balance. Another model where another point where I would like to make is, I think in the current system where we don't have a gatekeeper system in Malaysia, I think some of you are from UK, you will know that, you know, you can't simply just walk in a specialist clinic and say, I want to see a cardiologist. Whereas in Malaysia it's different. You know, you don't even have to call up for appointment. You just walk into the clinic and here you are. You're in front of a cardiologist, in front of a surgeon, a neurosurgeon, neurologist. So, and this thing is happening, and this is a thing which is undesirable. As a cardiologist, take for example, if I were to see a patient, I would rather have this patient seen by a primary care physician first. Because as a cardiologist, if I see the patient with an atypical chest pain, I'm compelled to do so-called unnecessary stress test, unnecessary echo, or high-tech cardiovascular test, because it is okay for a GP to miss a coronary artery disease, but it is disastrous for a cardiologist to miss even a minor or so-called asymptomatic coronary artery disease. So the standard of expectation is different. So it would be better if you have a primary care physician who has screened the patient first and direct the patient to the necessary or the appropriate specialist. Then we would cut down a lot of unnecessary investigation, unnecessary tests. So that will be the ideal system. Of course, that system is still not working in Malaysia. I think these are the ways where we are looking in the future. Probably by the time you graduate, by the time you are a physician, you are a specialist, hopefully, as what Tan Sri American was saying, hopefully we had the political view. I'm not sure whether we got the political clout to carry it. Of course, we like to do it, but we will see. Because at the end of the day, I do see that the current system, there are a lot of shortfalls, lots of things has to be fixed. What I think within the next few years, the first priority for us is to protect the lower income, low middle income group, where to make sure that this group of people still got quality, affordable healthcare. That should be our administration's priority. Whereas for the top 20, I think they can do whatever they like. There are always ways they can purchase, they can seek treatment elsewhere, they can even, lots of them I know, go to Singapore, go to Mayo's Clinic, go to Cleveland's Clinic, go to Johns Hopkins, and so on. Let it be. We are not going to restrict the private hospitals because they help to offload some of our government facilities. So we are going to work closely together between the private sector and the government sector. So apart from, as I said, apart from providing protection for the low income group, and some form of cooperation between the public and private sector. We are also looking at ways to improve what looks like severely stressed government facilities, trying to reduce the waiting list, improve the supplies, and car parks, things like that. These are the areas where we are looking at, and also provide better training for in-house physicians and paramedical staffs. We also had a promise, of course, to fulfill. We do say that, if Pakatan Harapan were to rule for the next 5 years, we are going to increase the healthcare expenses. Our total healthcare expenditure as of 2014, I think, is 4.5% of the GDP. And we are hoping that this should be increased up to 6 to 7%, which is the ideal situation for upper middle income nation. But bearing in mind, we are also we also know that we can't be just spending all the way just to achieve the target, because if you don't spend correctly, the additional money you put in for healthcare might fuel inflation. It might just fuel inflation, and it doesn't necessarily translate into better healthcare. So one of our priority over the next 5 years would be to emphasize more spending on primary care, more spending on preventive medicine, more spending on NCDs. So this will be our priority. Then the next thing is, when is this social health insurance going to come? I think that's what
Need to round up.
saying. This last minute. I don't see we can do it within the next 5 years. It has to be done with acceptance from the population, and it can only be done when people are willing to pay for their healthcare. Of course, it will be a better system than what we had now, because at the moment it's very fragmented, and we are actually working towards that. So I think for medical students, for future doctors, when such thing comes, there will be major landscape change, especially for this medical profession. No more, I think for those who are aspiring to be GP, I will tell you that there's no more treating cough and cold. Be prepared. Be prepared to be family medicine specialist. Be prepared to be family physician to look after families, and prepared to treat NCDs, and no more cough and cold. And for those who intend to specialize, I also got to warn you about the potential threat of artificial intelligence. I do foresee that there are certain professions in the future which might be severely threatened because of artificial intelligence. Take, for example, radiologists. There is a program already been tested in Korea where they read mammogram by artificial intelligence, and the result shows that the mammogram read by computer basically has got better results than better accuracy compared to renowned radiologists. So radiologists who are aspiring to be radiologists, take note. Same thing,
Bunchai,
dermatologists
I need to
and
stop you, Bunchai.
pathologists. Thank you.
Thank you, Buncha, for stopping that. Okay, we're going to move on, but before I move on, can I request from Dr. Calvin and the rest of us, no more salutations, no more greetings, no more hello, no more good mornings, no more YB, whatever. Okay, we've heard, we know who they are. Let's maximize our time to ask questions, okay? And Calvin Yee, there are 3 words to describe him. He's an MP, he was a doctor, he is a lawyer, and now, of course, he is a member of parliament. But there's one bigger word to describe him. He's a humanitarian. If you read his profile, he's done a lot of work on the ground, trying to uplift people who are disadvantaged. Can we welcome him, please?
Good morning, everybody. My name is Kelvin. Please don't call me doctor, don't call me YB. I love to be known as Kelvin. No salutations, my bad. So as a millennial, I want to tumpang glamour. I will stand here and speak. It's so good to see you guys. I don't remember the medical fraternity to be so good looking and so beautiful. I must be in the wrong batch. Please do not report me, it's a sensitive issue nowadays. Anyway, I just want to share, since Tan Sri and Dr. Lee Boon Chai has shared about the policies and the direction the medical industry, at least from the side of the government, wants to go. Let me share with you a bit more candid and my journey in why I believe and why I enter politics and why I believe politics play an important role in the medical field as well. So like Yang Berbahagia said, I was trained medical doctor. But since I was a medical student, friends and I, we have been for many humanitarian trips, medical mission trips, where we provide free medical health care. We provide awareness programs to the poor, to the marginalized in Sabah, in Sarawak, in many countries around Asia. I was in Nepal during the earthquake. I was in Philippines when the Typhoon Haiyan hit. I saw bodies everywhere. So we were providing the simple need, that the little that we can to the poor and the people that are in need. So it was there that my perspective on medicine actually changed. It is good. Doctors are so important. Doctors are really noble that we can provide healthcare, we can provide treatment to the sick, or we can provide food to the poor. The problem is, in many cases, even in our country, these people are poor because of policies that keep them poor, because of policies that keep them oppressed, because of policies that keep them marginalized. So there are really good people in the medical profession, but not so many in the political sphere. Now we are Dr. Lee, so it's a good thing. So that got me challenged, that in order for a full transformation of society, in order for a full transformation of this profession or this industry, there has to be a two-tier. The grassroots up, which is the doctors that's treating patients one by one, which is noble. I'm not asking you guys to throw off your coats and go into politics. We need both sides. One, and the other side is, of course, the politicians to come out with good, just and equitable healthcare policies and also other policies. So only through this merger that there is a full transformation of society. And this is something that I strongly believe in. So because of that, I sold my soul to politics. And trust me, in politics, there's not so much, it's not as grand as a lot of people think. There is no money in politics unless you're corrupt. See, I can't even afford to buy socks. But we just finished our parliamentary session, and it's my first time being elected. I didn't jump into politics straight away. I did my training in Kuching Hospital, and I helped my former member of parliament for Stampin and Bandar Kuching. I'm from Sarawak, best place in the world. Wuhua. Yeah, my man. So I was helping them to raise healthcare issues in Sarawak, to write their data, to do their research, and also to help with their debates. So it was then that they encouraged me and said, Kelvin, it's time for you to come back to Sarawak. I was based in KL at that time. Back to Sarawak and make a difference. So I sold my soul, I joined politics, and I was elected in this year. So this was the first parliamentary session that I was part of, and healthcare has always been core to my passion. So every healthcare debate that was in parliament, I paid attention. I gave a lot of questions. I burdened the ministry with a lot of questions. You can ask Dr. Lee. I came up to him so many times. And then I can tell you the main conversation, the main debates on healthcare nowadays. Number one, which is a good thing actually, mental health. Number two, building of more hospitals, clinics, especially in the rural areas in Sabah, Sarawak, and also in Orang Asli in West Malaysia. Number three, of course, was insufficient specialists in Malaysia, and how can we address that issue? Number four is, of course, the common NCDs, rare diseases, and all. So, from my observation, the narrative or the conversation, the debates on healthcare have not progressed from need-based in the sense that, oh, I need a clinic in my constituency. I need a hospital in my constituency. I need more doctors in my constituency. These are very important. Don't get me wrong. These are really important. This is a need that we need to address. However, the question we need to ask, especially as policymakers, does more hospitals, more clinics, more doctors, more ultrasound machines, more x-ray machines, does this really help address the core need or the core problem that we face in our healthcare industry nowadays? So is providing more infrastructure the solution? That's for you guys to find out. And that's for you guys to mature the narrative of healthcare industry. Let's now Dr. Lee touch on something which is very important and something we need to think about. That is a universal healthcare insurance. Sustainability is an issue that the healthcare industry needs to think about. It is very good to have free healthcare. It is very good to, and we, in Malaysia, we have one of the best, if not the best, affordable and accessible healthcare in the world. I was in the US about 2 years ago for a young leaders diplomatic exchange. And I was there when President Trump wanted to repeal the Obamacare. And trust me, America's healthcare system is not a system you want to follow. But then to really see the different system, NHS, the American Obamacare or whatever it's called now, and the current common multi-payer, single-payer system that we have. It's something for you guys to figure out. The medical industry is changing so quick. Young people, I echo what Dr. Amar said, that don't think that you guys cannot make a difference. I believe that young people are not just the leaders of tomorrow, they're leaders of today. They can influence the narrative of the conversation to push towards maturity of what we can see. What I want to see in Parliament, what I want to see the maturity in terms of our debates. We want to see more debates on the pros and cons of healthcare industry, the different policies in place, not just on building hospitals, but what is a proper policy we need to adopt, we need to implement. For example, universal healthcare insurance. How can we strengthen it? How can we crystallize to make sure no one is marginalized, no one will be left out, and then it's sustainable and we can reap the most benefits from it. One thing I want to see in Parliament itself is actually a select committee dedicated to health. This is practiced in many developed countries like the UK, where they call it, if I'm not mistaken, it's the Committee of Health and Social Care. In Australia, it's called the Committee of Health, and in German, it's Committee of Health as well. So what does a select committee do? Basically, in Parliament, Dr. Lee is part of the cabinet. The cabinet and the deputy ministers, they are the one that drafts the policies. I'm part of the backbencher. The backbencher in the previous administration has always been a rubber stamp to whatever that's been approved by the cabinet. But the real role of a backbencher is actually to scrutinize. We are the first line to scrutinize every policy that comes from the cabinet. So this is where the select committees are. The select committees consist of these backbenchers to actually take these policies, scrutinize it, inquire about it, ask questions, get the minister to answer, and not only that, by right, select committees can appoint specialists, advisors, appoint a smaller committee of stakeholders, as I said, specialists of the ground, doctors from the private sector, all kinds, NGO or what, to engage, to discuss, and to refine the policy that's at hand. And this is what is lacking in our system today. A lot of it comes straight from the cabinet, and the backbencher just, yes sir, ya tuan, ya betul. And this is not how we want to progress if we want to progress and mature as a nation. So young people, I believe in you all. You guys are not the lowest of the chain. So stand up, search deeper, dig deeper, expand yourself, believe in yourself, and I believe you can do great things. Thank you so much.
Thanks, Gavin, for taking the time. And can you please rescue the mic in the rostrum? There's one more mic in the rostrum. You just rescue that. Thank you. Now, I'm going to invite you to start asking questions. You can also make comments which we could respond to. Not everybody on the podium needs to respond, but we will try. But can I start off with one question? I'm going to ask the panelists to respond. And one of the key issues that we have today is that our public is addicted to a curative service. For a long time, we've fed them this service. Huh? You got a problem, come see a cardiologist to fix your heart. You got a problem, come and see an ID person, they give you an antibiotic or something like that. And so they are tuned to this. They have no concept of preventative service. There's also a hidden agenda in this. The private sector thrives on disease, not on prevention. I don't know anybody in the private sector that does prevention actually at all, as that issue. And there's also another hidden agenda. Our entire development of subspecialists is skewed to disease as well. So now we have lost our generalists. And so the role models that you have, and the ones I had also when growing up, is who wants to be a primary care specialist? I mean, who wants to be a public health specialist? You want to be a neurosurgeon or cardiologist? So your role models are the ones that you look for. And this hospital here, this university here may also be treating you that way, teaching you about disease rather than prevention. I often call the Ministry of Health the Ministry of Disease rather than the Ministry of Health. 70% of our budget goes to disease, to hospitals, 30% goes to health. Something's wrong with this equation. Of course, the budget is insufficient, that's part of our problem. So I'd like, first of all, to ask this question, how are we going to deal with this curative versus preventative divide, this hospital versus health divide, and not just the issue of turning around the country's mindset, but also turning around the health professionals' mindset that 70% of the people in this audience are going to choose to become public health specialists, where there's no private prospects at all. The silence, of course, yes, okay. Okay, I'm happy for any one of the panel to start off. Keep a mic each of you.
I better speak before the two politicians start speaking. It will never end. Sorry. Okay, now, Amma, we have raised very important questions. I agree that in the past, there is technical as well as allocative inefficiency. And what do I mean by that? A lot of money goes to curative health services and not many go to the preventive care services. These needs to be addressed. And I do echo what YB Bunchai said just now. We must strengthen primary care. All right? And that was part of the reform when Azrul asked me to speak the other day about reforms. I mentioned 3 things. 1 is integration of the public and private sector. 2 is strengthening primary health care. And 3 is introducing some form of healthcare financing. All right? But we can't address 2 of those issues because it's in another forum. But strengthening primary care is very, very important. And that means bringing primary care closer to the community. People must take care of themselves better. There must be self-awareness, and you must be able to treat yourself better. Right now, you are too dependent on the doctors, all right? For even a small headache or fever or cough, you can say, doctor, you don't have to. You can, provided you get the right information, not from the internet, from a reliable source like Ministry of Health, for instance, through the portal, through ICT, you get the right information, you'll be able to manage yourself better. You have to be responsible for your own health. The other thing YB Lee mentioned was part of the deal that I had with the Academy of Family Physicians. There is no such thing as GPs in the future. We don't want you to be GPs. You must be primary care physicians, at least, so that you'll be able to do 2 things. 1, improve the quality of care at the primary care level. The other one is to act as a gatekeeper. And I agree with this gatekeeper role very, very strongly. You don't go straight to the hospital, you wait till gatekeeper, and they will decide whether you need to be admitted or referred or whatever. I mentioned this, as you remember, there was, when I presented this idea of gatekeeper to the Economic Council, there was an Economic Council in those days, so very, very powerful, chaired by the Prime Minister and all that. So I mentioned about the gatekeeper's role, and then one of the ministers, which I won't mention the name for security reasons, he said, if I have chest pain, I might as well go to IJN. But then I reminded the minister, politely of course, you must be polite with all the politicians. I said, if you have chest pain, there are 10 causes of chest pain. Doesn't mean that all chest pain is due to coronary heart disease. So imagine if you have seen an IJN specialist, he will have to do all those tests, which are quite unnecessary. But that YB Lee said, you have to do that because it's disastrous for a cardiologist not to do those tests to ascertain that this is not due to heart disease. So if you have a gatekeeper, a good one, and that's why we're working with the Academy of Family Physicians, strengthen primary care, ensure that they're of good quality, they will decide whether that chest pain needs to be referred to IJN or it can be managed elsewhere. So those are the things that I want to say. More allocation should be given to primary care. Strengthening primary care is very important, and all of you must also be responsible for your own health. All right, don't depend too much on the doctors. Now the other thing, if you may, I may mention about public health specialists. Now public health specialists are also very important, but we need to improve the quality of public health in this country. That we need to do, and I'll only elaborate further because we don't have time. Thank you very much.
Bunchai, Kelvin, any idea how we could push our colleagues to the primary care and move the whole primary care machinery back to having a primary focus rather than a secondary focus?
Well, I think a lot of the time related to allocation. I think when there is appropriate allocation in terms of posts, in terms of promotion prospects, and then there might be more people willing to do primary care. That is on the private provider side. Of course, in the public, in the general public setting, then we still need to educate our public to accept the concept of family physician. So there are lots of work to be done. I can see that even though we have the change of administration, we have new government for 100 days, but the core value, what Tan Sri Ismail has said, I think we all share a lot of the core value of what it should be. And I think that should be the driving force for us to work that point. I just want to emphasize, we have spent too much time on treating the sick, but not enough resources to keeping them healthy. And at the moment, we can see that this is the result of the previous administration. I must give them the due credit. We have about 332 FMS, so-called family medicine specialists, and we are going to have more of this, so that the standard of primary care can be enhanced, can be improved, and hopefully whole thing could be better. Of course, I do buy into so-called integration of private and public healthcare. That's where we are going to look into public and private partnership. But abrupt integration is, at this point in time, cannot be done, because there's too much of difference between the two systems. So we need to bring the two systems, the private hospital and the government setting, closer together in terms of level of service, expertise, staffing, and so on, so that we can integrate seamlessly when the time comes. I think that's what I want to comment.
I think there has to be a mentality change among the society as well, because primary care has never been given a focus. It has never been given in a way a noble connotation to it. I think every parent, when you become a doctor, the first thing they ask you, so you want to be a cardiologist, internal medicine specialist, or nephrologist or something. So primary care, public health has never given an emphasis. And the reason why is because many of the doctors itself do not know the importance of it, and also there's not much profit to come from it. So as I said, we are in this profession because we want to help people. Of course, that's the core value. So is profit or helping the main driving force that that makes us do what we do? And that's the question that we need to ask ourselves. So if we are really helping, we are really trying to make the community better, primary health is actually, and preventive medicine is actually the way to go. Let me give you a context and an example. In Sarawak right now, we are facing a rabies epidemic. And rabies, as you know, it's a preventable disease. We have never had it for the past many years, but suddenly it was detected last year. And so far we had 12 human cases. 12 human cases, 10 has died, 1 is in ICU, one is on life support. Even though he was discharged, he's on life support at home. It's an 11-year-old boy. So to hear stories like this, for a preventable disease, one of the case that died was they actually went to the clinic, and the GP did not misdiagnose, did not catch the symptoms, even though there was a clear bite, and did not give him the vaccination, and he passed away. So all this could be prevented if the primary health care was strengthened. And then another issue that is, even if you look through the manifesto of Pakatan Harapan, especially for Sarawak and Sabah side, there is a policy that we talk about, which is decentralization of healthcare. Decentralization is not just allocating autonomy and powers to the state to decide, because in theory, the state will know the needs, the local needs, in comparative to waiting for a federal decision. So like in Sarawak, we have lack of, for example, doctors, we have lack of, the clinics are in dilapidated situations and everything. But it's not just that. Decentralization also means to move away a huge chunk of patients from the tertiary hospital, which is the only tertiary hospital in Sarawak, for example, is Kuching. It's way too congested. And I've got friends who are specialists that see, as I said, all kinds of people come in right to the top. But how can we decentralize more primary care clinics to the smaller desas, to the smaller districts, to the smaller kampongs? But that is one issue itself. So yeah.
Thank you, Kelvin. In addition, don't forget that 40% of all our specialists are in the Klang Valley Black Hole, which we don't like. And universities are still very disease-focused rather than preventive care. Universities have to change as well. Now I'm going to take questions not from the people on the front row just yet, but people from anywhere else. Yes, go ahead. After this, the conveners cannot speak anymore. Yes.
Okay. Okay, so good morning, everyone. My name is Vigneshwar. I'm a health officer and I'm also the community officer.
Closer mic, please.
Right. Can you all hear me now? Thank you. So thank you so much, kind sirs, for being here. I'd like to ask questions regarding the topic. So, politics in healthcare. So, as much as we would say the people here are the drivers of change for future, we cannot deny the fact that politicians are the people who actually bring about change. Not all doctors become politicians. How is the level of healthcare literacy or health awareness among politicians now? Because these people are the ones who are going to be making decisions. They have to push for it. If we don't have politicians pushing for health change, it won't happen. See, we have a Wiley Kevin. He's a doctor, so he's pushing for rabies. That agenda has been discussed. So, and it's good that it's happening in his jurisdiction, so he can talk about it. If the politician is not aware of such a thing, he is probably not going to bring it up. How do we change this? What is happening and how to address this issue? Thank you.
How to grow the healthcare awareness and capability of our politicians, yes. Anybody want to pick it up? We'll take one person only.
By the way, politicians, all the MPs, they are called Wakil Rakyat. Wakil Rakyat. Wakil Rakyat means they represents the riot. The quality of MPs is a reflection of the riot. So the quality of the riot, that's where they select those MPs. So I will say that at the end of the day, I do know that a lot of MP doesn't know health very well. That's where I do agree with Kevin's suggestion that in health issue, there should be a select committee who address this health-related issue. Then that would improve the quality of the debate in Parliament. Thank you.
Come on, other people, please come and stand at the mic. You've got a question, so I know you're there. Questions, please. No question is stupid. Yes, please come. Just come to the mic. Yeah, mic can move as well.
Hi, good morning everyone. My name is Steven and I'm from local private view. Thank you very much for the speech, and I truly agree that free healthcare is definitely not able to be available in Malaysia. But the thing is, over the high cost in healthcare, besides of human factor, is it a possibility that, for example, in financial wise, that the tender, for example, is awarded to some for example, medical devices, for example, that the results may not be accurate, and that's why patients keep coming in, and with inaccurate results, patients are getting sicker. And also on the generic drugs that we have been using and also prescribing over the time, and we know that generic drugs may have the same efficacy as the dominant drugs, but it's cheaper, but sometimes it may not work as a generalization. And also for YB caveat is I know that in Kuching Sarawak General Hospital is that they have been so pushing factor to establish a one building lab for itself, and this has been happening for the past 10 years and it has never been. So may I ask is, for the new government, it's not fair for us to push for a change, but what would be the small change that is noticeable and significant that will be observed in these 5 years? Thanks.
You take any part of the first part of the question, yes. Kevin, you take the second part.
Thank you. Now, the first part is about healthcare financing, whether we are spending enough on healthcare. I think there was a survey that was done not too long ago. Malaysia spent about 6% on healthcare, particularly of the national budget, compared to countries like Singapore and Vietnam, we spend about 30 to 40%. And globally, if you look at most countries around the world, they spend twice more than what Malaysia spends. All right, so we are not spending enough on healthcare, number one. Number two, just now it was mentioned that the GDP, 4.5% of GDP for healthcare is not enough. We want to increase it about 6%. But I would like to caution here that increasing the GDP is not the only solution. If you want to increase the GDP, you must also institute the healthcare reforms. No point pushing up the GDP without instituting the healthcare reform. Like what we mentioned just now, it will go to waste anyway. So you increase money, you spend more, that's all. But you must have the reforms, At the same time, you increase the GDP to about 6%. That will work. Okay? Now, what else?
Yeah, that's fine.
That's fine. Right? Is there anything else that you haven't mentioned? That's fine. Okay, thanks.
Yes, Kelvin?
Thanks for taking a concern on Sarawak General Hospital. Do come to the hospital. It's one of the best places in the world. I say this all the time. So basically, you are right to point out in Sarawak General Hospital, there isn't even a hospital integrated system where the lab results or any result is been integrated in the whole hospital. When I was a houseman, I still remember when we take bill spreads and blood results, we have to run from the 9th floor of the medical ward right down to the ward and run up again. And it's still now the current rate. But what is improving and what is being done right now? We are actually building a lab, finally, in the Sarawak General Hospital, and that lab will be integrated on top of a pathology lab, on top of more beds and different things. So this project was actually promised in the previous administration. It was delayed for about 15 years, and it actually started last year. So I've spoken to the contractors and also the director in the state. So because it's a private PPI, public-private initiative, so there is some profit driven. That means after a while they build that, then they get back certain costs. So because it's PPI, the contractor has every incentive to finish it on time. So it should be finished in 2021. So yeah, thank you.
Thanks, Kevin. We're going to move to more macro issues. Then let me ask one while you're thinking of a question. One of my major concerns is that there is almost no public engagement in deciding how our healthcare reforms go. A lot of the policy decided at central level, at cabinet level, at Minister of Health level. Even Minister of Health level is centralized to very few people. There's little engagement of the average person. None of you have ever been asked what you think about where a healthcare service should go. Okay, so I want to ask, who decides? How do we decide? How do we engage the whole country? As Tan Sri said to me over this morning when we were talking, the time for somebody in the center to make all the decisions is gone. We all have a role and involvement and ideas, and we somehow must be able to tap on those ideas. So we start with Tan Sri and then Bunchai, and Kevin, if you got anything you can chip in.
Okay, since I was in the government before, perhaps I will let you know how we do healthcare policy. There is such a thing as the 5-year Malaysian plan. Have you heard of it?
Yes.
So now we're into the 11th Malaysian plan, 2016 to 2020. So that's how we work policy. We engage people, hopefully enough engagement, but maybe not enough. But the main theme of the 11th Malaysian plan is anchoring growth on people. And its health focus is to ensure that people achieve universal access to quality healthcare. Very loaded statement. And the vision expressed was that every Malaysian will have equal access to affordable and good quality healthcare services, either in the public as well as in the private sector. And they had 4 strategies. Strategy 1 is enhancing targeted support, particularly for underserved communities. Strategy 2 is improve the delivery system. And number 3 is expanding the capacity to increase accessibility. And of course, strategy 4 is intensifying collaboration with the private sector and NGOs. But I would like to stress here again and now, I mentioned this to Amma this morning, the days of government nose blast are over. You must have feedback from the ground. That's why I wanted to see the minister and perhaps the deputy. You were not appointed yet, Datuk Lee. If you had been appointed, I would have seen you first. But I wanted to see the minister before he goes into the Ministry of Health. Because once you go into the corridors of the Ministry of Health, you may be swayed, all right? You may be influenced. So I've been inside there and I've been out. So perhaps it will be good to hear from me what is happening out there. So limited public engagement and involvement in planning and the design of the healthcare system will cause problems in implementation. Whatever you implement, there must be acceptance. And acceptance will only occur if you have been engaged. If they ask you to be engaged, let them know about your problems. Because if you start something and then you implement and then you don't get the acceptance and then you have to retract, it's embarrassing. So what I'm trying to suggest here is they must have very strong engagement with the stakeholders.
How to get engagement?
I think there are various ways. I think we are here, a new administration, 101 days of the new Malaysia. So what we have done, I think you have seen in other ministry which has been doing is, one of the things we do is town hall. Town hall meeting, we bring in all the stakeholders Of course, at the ministry level, we do gather groups of people with interest, and then we discuss closed door. Also, of course, now with the social media, sometimes we throw bits and pieces of information and see the feedbacks, and that will help us to gather what can be done, what cannot be done, and where the boundaries are. So these are the way forward. I think there will be more town hall meeting. I think for under Ministry of Health, there will be one town hall meeting very soon for about GP charges. I think there will be different stakeholders will be having an open discussion, open forum to discuss on the GP fee schedule. And these are the things where we are going to implement in years to come. I think between the next, from now until budget, I'm sure you will see more of this sort of engagement, and we are committed to that.
Kevin, how can we get a groundswell of people coming and influencing policy?
Okay.
Which is not happening.
I think, as I mentioned just now, for me, I believe in the Parliamentary Select Committee on Health.
Okay.
I think we need to enrich the politicians' debate on healthcare. And through that parliamentary committee, they can appoint people, different stakeholders, different specialists in the field to advise and so even to refine the policies. As Tan Sri mentioned, a lot of the policies come from the ministry, and then a lot of people want to change, but their hands are tied on everything. So through that parliamentary committee, hopefully we can enrich the debates. Of course, there is a mentality change. We need to get people more involved. I think in Malaysia, at least the experience that I have in my constituency, people complain, but they don't want to get involved. Why do I waste my Sunday afternoon to come for a forum? Why must I come? Or it doesn't, I one person, I cannot make a change. The fact is the matter is your opinion, no matter how far-fetched it may seem, can actually polish a little bit. So we need to have a mentality change. We need to encourage one another. All you need is a few small group of young people or elderly people that is passionate and is like-minded and just move the thing.
My taxi driver, who I've been using for many, many years, is very astute and has many interesting policy decisions. Even this morning, he gave me some advice about this session.
Thanks, Amar, and thank you, Dr. Lee, for coming to this forum. You know, whenever we talk about healthcare, we always hear about there's not enough doctors, there's not enough specialists, but there's almost a vacuum of discussion around nurses and allied health professionals. If we're going to expand healthcare to all, you know, it's going to take us another 100 years to have enough cardiologists or whatever, despite our best attempts. We really need to expand specialist nurses. We really need to expand case managers and social workers and physiotherapists, etc., etc. I don't hear any discussions going on about this, and I think this has to be highlighted, because in Sarawak, for instance, you know, major task shifting is going to have to occur if you want to give good healthcare to everyone, and I think these people are some of the people that you need to rely on. And plus the aging population, you know, we doctors can't do everything. That's one. And the second thing is, you know, I take your point about us not teaching enough preventive care, and you know, we also do try and address it. The social determinants of health is another thing that we don't highlight. You know, I'm working with YB Maria Chin and her volunteers in Taman Medan. And our students just did a wonderful survey of the needs of the Taman Medan population. 90% of them are B40s. 56% are obese. We're not talking about just overweight, obese. Why? Because their health literacy is low, because they can't afford fresh fruits and vegetables and all those things. So they resort to rice and sweet drinks to fill their empty tummies. So, you know, those things, the social determinants of health, you know, the lack of space to exercise or to even just run around, not even have exercise, but to just run around. So there are many aspects of health that, you know, apart from increasing the finances, that we need to address.
Thank you. I'm not going to take any responses to that. I think that's a wise words. One more question, please. Yes, please go over there. Sorry, his hand was first. Yes. Yeah, just throw the mic at him or something. Yes.
Hello, hello. Hi, my name is Daniel from IMU. So basically, I have just two questions. On the first one, I just like a bit of clarification on the social security insurance thingy that you're trying to talk about. Because when I hear insurance, I'm thinking already in the future as doctors, will we be overcome by paperwork? Will we have to jeopardize quality of patient care to suit the insurance company's demands, or would we have to justify it to them? So that's one of my concerns. So just a bit of clarification
Answer
on
a
that.
quick thing, the way Boon Chai and other people are thinking, for the bottom 40%, government buys for them. And government pays back the service provider. You just go there and then government pays back. There will be some paperwork, but I don't think we can answer right now your question how much paperwork, but we have the same concerns you have. But basically, the bottom 40% does not buy insurance. Insurance is bought for them. Okay, yes.
The second one, a little bit more on a more personal level, just curious, and if you're willing to share, what made you branch into, like what was the deciding factor between switching from medicine into politics? What made you, as Dr. Kevin keeps saying, selling your soul to politics and all that? Was it worthwhile to like give up seeing patients on the ground level to make these larger policies? And second part to that, so sorry, is when you're in a situation that is frustrating, that because of the politics of the system, you're unable to invoke that change. How do you manage that?
Kevin, quick comment from you.
I think we need to set clear that being a politician doesn't make you better than being a doctor. At the end of the day, we all play our roles, whether you're an engineer, you're a lawyer, and everything. But at the end of the day, what drives you? What is your passion in doing things? Everybody play an important role. Yeah. What is your second part of the question? I forgot.
When you feel stuck,
Stuck in the system.
Yeah.
So I think the one question that got me into politics is when my previous MP says that, Kelvin, we need more good people in politics. And I'm not saying that I'm a good person or a great person, but in order to break the shackles or the whatever influence that is, we need more good people. People always say there are not enough good people because good people don't join. There are not enough young people in politics because young people don't join. So in order to do that, we must make the difference ourselves. Thank you.
Boon Chai, something to say?
Yeah, I think that's a very important question for politicians or aspiring politicians. I think at the end of the day, the most important thing is you must believe that you can do something, you can contribute something and make change possible. I think I joined politics in Reformasi era where I was fighting Mahathir. I was cursing him. I was so angry that he destroyed the judiciary system. He really destroyed the institution of democracy. That's where which drove me into politics. And today, I work with him. Because I think throughout 20 years of Reformasi, at least we have reformed Mahathir.
Yeah.
So I think that's the most important thing. Of course, at the time when I was offered Deputy Health Minister, I was reluctant because I have easy life, treating patients and so on, and it was such a comfortable life to be just like walking in the gardens, so straw, enjoying your life. But when second call came, so I think I cannot resist. So, of course, it is now in a highway. But I do think that, I still believe that there's something where my knowledge, my expertise might be of help to the Ministry of Health. And that's where I believe that I can contribute to a betterment of the healthcare delivery system. That's where I am. I do hope that all of you do join us. Let us make Malaysia better.
Thank you. One last word from Council Eastern America.
Thank you very much. Well, you know about the Reformasi and Mahathir and all that, but never mind. Now, my last word is this. I've been talking about reforms since the day I joined the Ministry of Health because I was very taken in by some of the difficulties that I saw with the patients that I met earlier. The first thing, of course, as I mentioned just now, is the integration. Maybe Lee Boon Chai was saying it might be difficult to do it within the next couple of days or it may take years and all that. But I'm not saying that you do integration overnight. Integration can never be done overnight. Two different systems. But you have to start somewhere. You have to do it incrementally. And I say we start with OPD care. Why? Why outpatient care? Because that is where most visits are made, and that is where most out-of-pocket expenditure has been done by most of us. So we do it in an incremental manner, starting with primary care and see how it works. Okay, that's number one. Two, about the strengthening of primary care, we are all on the same page. More resources, of course, but please remember, we have all have a responsibility to take care of ourselves and our loved ones better. So for that, we need information, and we hope the Ministry of Health will provide accurate and reliable information for us to take charge. And the third one, of course, healthcare financing. And I feel very strongly, I was crusading this in 1998, it has to be mandatory. Those who cannot afford, fine, but those who can afford, they have to pay some form of premium to ensure we have a sustainable healthcare system. That's all I have to say. Thank you so much.
Thank you. Now, we've not covered many areas, and I hope you think about them. We haven't covered injuries, which are an enormous burden. We haven't covered air pollution, which is going to kill many of us. We haven't covered issues of marginalized children,
Hi,
especially.
Sorry, just
Yeah.
I think a few of us are. I'm
Yeah.
really sorry to cut you off, but I think I'm just echoing a lot of sentiments for a lot of my colleagues. I'm just going to point out an elephant in the room that a lot of us are wondering about. Is the issue of mono ethnicity that's been getting louder over the past few years. But now with the new administration, I guess just something for all of us to think about. What's the role of it now in the current administration? Like, what do you think is going to happen to the administration and the issue of mono ethnicity? Maybe you can have a little talk about this later privately. And I guess also, lastly, maybe you can do a one-liner over this is, to the whole panel, given the current machinery that we students have coming out of graduation or in medical school, and given the current knowledge that you possess all these years, and the system that we're in, what is the one thing you would do actually if you were able to come back into as a medical student in this day and age? What would you do?
Apologize, our time actually is up, and now convener has been pressuring me to stop. Okay, but I want to continue just for a moment. So I think mono ethnicity is on my card of things to bring up, but we didn't get there. Where many of us are worried about the mono ethnic change in our health service, and we want to reverse that. But think of the other things I mentioned. Air pollution is a crisis, injuries, marginalized individuals, especially our indigenous and immigrants and inner city individuals, that we're not addressing at all in any major way. So I hope that what you take away from here is that you are a participant, not a recipient. And I hope that you will think about it. I'm going to end with a poem from Tagore, a favorite poem. I think Azrul and I are good friends with Tagore. Yes, agreed. You can always give questions and people can try and answer that. I'm happy to talk to you about the mono-ethnic suggestion as well. Is there a possibility, convenient, to post questions where...
I like that.
Yes, so it's possible. Okay. So let me read this poem as an inspiration to you. I hope to change. Tagore is a guy who never went to school and won a Nobel Prize. So that says quite a bit about him. Where the mind is without fear and the head is held high, where knowledge is free, where the world has not been broken up into fragments by narrow domestic walls, or ethnic walls for that matter, where words come up from the depth of truth, where tireless striving stretches into arms towards perfection, where the clear stream of reason has not lost its way into the Deary's desert sand of dead habit, where the mind is led forward into you, God, into ever-widening thought and action, into the heaven of freedom, my country, into the heaven of freedom, my Father, let my country awake. And I think that's what we want for Malaysia. We want to come back to reason, to meaning, to come back to the ground, to reality, to change. And remember that you are the one who's going to make it, not just the people on the podium. Thank you very much. Thank you for coming.
Ladies and gentlemen, please give them another round of applause for our wonderful panelists. Now, if all of our panelists and the moderator could stay on stage.